So today I'm going to be talking about spine biomechanics. When I was in college, obviously I got interested into neuroscience, but initially I was interested in engineering, physics, um, and so I wanted to take a look at the spine from a physics perspective and how it allows us to walk with minimal effort to maintain an upright posture. Um, so the outline for today. I'm going to talk about differences in humans versus mammals and apes that allows for bipedal locomotion. Um, talk about normal physiology of the spine, importance of spinal alignment parameters, uh, the effect of age on normal physiology, and the physics involved when talking about surgical fusion. So, most animals in the animal kingdom are four-legged. They can walk on two legs, but it takes a great amount of effort. Like if you take a, look at a chimpanzee or a gorilla, they can walk on two legs, but they can only do it for short periods of time. So what makes us able to do this? How are we able to walk on two legs without, really even thinking about it? We're just, I would say that a majority of this ability is because of the shape of our spine. There are obviously other things involved, like our feet, that allow us to maintain this upright posture, but the spine is what really makes it easy for us to walk from place to place. So it's just a direct comparison between, our closest relative, chimpanzee, and humans. A couple of things I'll point out. The foramen magnum is actually in the back of the head of a chimpanzee because they spend so much time on four legs, or their arms and legs. So it allows them to look forward without having to keep cranking their neck back, unlike us, where the base of the skull, the foramen magnum, is at the very bottom, which allows us to maintain a horizontal gaze with respect to the horizon. If you look at the torso of the chimpanzee versus a human, the torso of a chimpanzee is much bigger. You can see the rib cage is wider. It is supporting a little bit more weight. Because of this, that you have this large weight hanging out in front of the chest, it's going to want to pull the chimpanzee forward. Our rib cage is smaller; it doesn't go out as far, and it allows us to keep our center of gravity farther back. Looking at the pelvis, the chimpanzee pelvis is much more flat because it doesn't have to accommodate for all of the organs kind of shifting down with gravity when they stand up. That's why our pelvis is a little bit more bowl-shaped, so that our organs don't kind of just hang out all the way down towards the bottom. Their feet are, they walk on their feet, but they also use their feet for grabbing things. That's the biggest difference between their feet and our feet, that they still have opposable thumbs on their feet. The shape of our feet has an arch on it, and arches, as many of us know, the arch is one of the main types of bridges that can support a lot of weight, and that's why our feet have that arch in it. And then kind of getting back to the spine, if you look on the right here, their spine is, again, arch shaped. And why is that? The arching of the spine is made to support the weight of their torso, while the S curve of our spine is made to just maintain a center of gravity above the pelvis. And allows us to use minimal energy in order to stand upright. So I'm going to go into normal physiology. I'm going to focus a little bit more on the lumbar spine, just because this is where a majority of our weight bearing occurs. There are 5 lumbar vertebrae. You have the transverse processes, you have the spinous process, facets here, superior articulating facet, inferior articulating facet. The main movements of the lumbar spine are flexion extension. There's a little bit of rotation, a little bit of lateral flexion. The structural support of the lumbar spine, there's the bony support, which is the 3 columns. You have the anterior column, the middle column, and the posterior column that are supporting the weight of the body. You have the ligaments of the spine. You have the ALL, the anterior longitudinal ligament, posterior longitudinal ligament, ligamentum flavum here, the interspinous and supraspinous ligaments, and then the musculature of the back. The main erector muscles that we'll focus on is the erector spinae and the multifidus that allow us to maintain this upright posture. So looking at the physics of the spine, there are, 5 main types of forces that we talk about in physics. There's compression, tension, bending, torsion, and shearing. For obvious reasons, I'm not going to be talking about tension. I'll be and bending, either as well, because our spine bends, but it's the physics of bending is the solid portion. There's not a lot of bending moments within the spine. That's why we have our facets, to allow the spine to bend naturally. So it's not resisting bending. So the 3 main forces I want to talk about initially will be torsion, shear, and compression. So torsion is basically strain that occurs when you rotate an object on itself. The resistance from torsion in the lumbar spine comes from the annulus fibrosus, but mainly from the facets. If you look at the orientation of the facets in comparison to the cervical facets specifically, our cervical spine has a lot of range of motion in terms of rotation. That's because the facets are oriented differently than the lumbar spine. In the lumbar spine, they are oriented in a more sagittal plane. And when you rotate your lumbar spine, the 2 facets push upon each other, preventing from further torsion forces acting upon the spine. And that's really to protect the annulus fibrosus from excessive torsion forces that can lead to disc rupture. But the orientation of the facet does allow for flexion extension, but resists torsion. Shear forces. Shear is a little bit more difficult to understand. A lot of times people talk about shear forces where you have 2 objects that are kind of glued to each other. One object's being pushed to the right, the other object's being pushed to the left. And that is a shear force on the entire system. Shear is occurring at all times when we're standing. Your posture and your spinal pelvic parameters, which I'll go into a little bit later, can greatly affect the amount of shear force that your spine is resisting. And resistance to the shear force is from the annulus fibrosus, but mainly from the facets. They resist 78% of the shear forces that are present in the spine. The orientation allows for the superior facet to push back against the inferior facet. And one thing I want to point out to you is the difference between the facet orientation within the lumbar spine. So as you travel down the lumbar spine, once you get down to L5S1, they're much more coronally oriented. And why do you think that is? If you look up at the top of the spine here, the disc or the vertebral body is almost parallel to the floor. So the shear force would be acting in this direction. But because your weight is pushing down, none of that force gets transferred out this way because it's perpendicular to the vertebral body. But if you move down to L5S1, where the slope has increased and it's not parallel to the floor, that's when you start to get shear forces, because the weight of your spine going down this way and your body going down this way, some of it is converted into compression force down the spine, down the internal axis of rotation of the spine. And the other part of that force is creating a shear force. And obviously, a lot of their shear force occurs down here at L5S1. So our facets have been oriented in such a way in order to prevent slippage of the vertebral body over the next one. The pedicle also has to resist, obviously, the shear forces, because while the facets are bumping against each other, the pedicle has to resist the vertebral body moving forward. And then the big one, compression, who's carrying the load? Is it the bone? Is it the muscle? Is it the ligaments? Is it the disc? It's mainly the bone and the disc. I'll start with the bone. If you look at the spine in its entirety, you can see that there's increasing size from the cervical spine down to the lumbar spine in terms of vertebral body size. That's because obviously we have increasing weight as you go down the spine. Each vertebral body has to carry more and more weight. Wolff's Law, which may seem obscure, but was actually tested on last year's boards, is basically increased strain on a bone leads to remodeling and increased stiffness of the bone. So if you're someone who's very active, then your bone is going to be stronger than someone who kind of just sits around, in a chair all day or is bedbound. The vertebral bodies are anisotropic. When it's anisotropic, basically, isotropic is an object that can resist different forces in whatever direction equally. Anisotropic, such as our bone, has different strengths based on the direction of the stress. So the way the trabecula are in the bone or in the vertebral body are very good at resisting compression, but not very good at shear. Now, the intervertebral disc is probably one of the most important parts of the ability of the spine to resist compression. It obviously acts as a cushion between each bone. You have the nucleus pulposus in the center here. As you stand up, the vertebral body pushes down on the nucleus pulposus, which then pushes outwards towards the annulus fibrosus. Then the annulus fibrosus, which has these 30-degree fibers that are kind of interlocking to increase the strength of the annulus. Basically, the annulus then resists that resists the pulposus, pushes it kind of back up, and acts as a cushion. This is important because it allows the force of compression to be dispersed evenly across the vertebral body and allows for a follower load, which I'll get into in the next slide, across the spine. Like I mentioned before, the annulus fibrosus is good at resisting the force of the nucleus pulposus outwards. When you lean forwards, the pulposus moves backwards, and then the back part of the annulus is resisting that. And then when you lean backwards, it's the opposite. The pulposus goes forwards to where there's less compression, and then the annulus resists that to prevent excessive extension flexion. So what's the importance of a follower load? So basically, the follower load means that the force of compression is basically following the curvature of the spine. This is what really allows us to maintain our posture without significant energy expenditure. They looked at cadaveric spines and compared the change in lordosis with increasing loads in vertical versus follower load models. Basically, you can see here, even with very minimal compressive load, the spine just kind of wants to fall backwards. You get a large amount of vertical tilt of L1, but in the follower load, even as you go up to compressive loads of 1,200 newtons, you barely get much change in the tilt of the spine. And this allows for the stress shielding, which allows for a majority of the pressure to be applied on the vertebral body versus the posterior elements of the neural arch. And next, I'm going to talk about the importance of the spinal parameters. So the spinal parameters is, again, very important in maintaining erect posture with very minimal effort. This is how we maintain the center of gravity over our pelvis, which is the base of our entire spine. So the lordosis of the cervical spine and the lumbar spine should equal the kyphosis of the thoracic spine and maybe partially the sacrum. And then also the sagittal vertical axis, you want to be directly above the S1 vertebral body. So, in order to have a strong tree or a strong structure, you have to have a strong base. And the base of our spine is where it attaches to the pelvis. And so there are three important spinal pelvic parameters. I'm going to discuss pelvic incidence, pelvic tilt, and sacral slope. So pelvic incidence, the important thing to know about this is fixed. It changes throughout your adulthood, but once you achieve skeletal maturity in adulthood, that's when it becomes completely fixed. On average, it's about 55 degrees, and it describes the relationship between the femur and the sacrum. So the way you measure pelvic incidence is you take the midpoint of the sacral and vertebral body, 90-degree angle out from there, and then the other line goes from the midpoint to the middle of the head of the femur. There's a special relationship between pelvic incidence and lumbar lordosis, which I'll go over again, but they should be within 10 degrees of each other. Pelvic tilt, this is positional in nature. It's one of our compensatory mechanisms in correcting positive sagittal balance. If you increase your pelvic retroversion, you're increasing your pelvic tilt. And if you look down here, this is kind of normal alignment. You have, this is your pelvic tilt here, small angle with a large degree of lumbar lordosis. But as this patient starts to lean forward, the center of gravity is now kind of way out over here. So what the patient starts to do in order to compensate for that is to kind of tilt their pelvis back, which increases their pelvic tilt and therefore brings the center of gravity back kind of over the pelvis and in the femur. Sacral slope is similar to pelvic tilt. It's another one of our compensatory mechanisms for correcting sagittal balance. And also changes with pelvic retroversion. And that's because pelvic incidence is basically sacral slope plus pelvic tilt. Sacral slope will usually make up about 60% of the pelvic incidence, and the pelvic tilt will make up 40%. But that can change as a patient kind of does pelvic retroversion to maintain posture. So we want spinal pelvic harmony because if your spine and your pelvis are kind of out of sync, then you're going to be requiring other parts of your body, like you're going to be putting more strain on the anterior column. You're going to be using more of your spinal musculature to help maintain upright posture. But like I said before, lumbar lordosis should equal pelvic incidence with an ideal difference between 10 degrees. Patients with a higher mismatch have been shown to have higher ODI scores. You can see that the changes in lumbar lordosis leads to changes in lordotic apex. As the lordosis increases, the apex travels rostrally. So as there's more lordosis, the apex of your, which is important to keep in mind for surgery, that you're not kind of cranking them back up here when they needed to be cranked lower down. Other compensatory mechanisms, like I said, pelvic tilt, bending of the knees, kind of splaying open of your hip joint, which kind of like a crouched posture, allows to maintain sagittal balance. But obviously, it's like these patients are, if anyone's ever done like a wall sit for an extended period of time, these patients, get extremely exhausted. They get a lot of leg pain, a lot of back pain from just trying to stay upright. And then talking about global alignment, the sagittal vertebral axis is one of the main mechanisms that we use to measure global alignment. So you take the C7 plumb line, you take it all the way down, and you want to see how far forward it is in front of the back of the L5 or S1 vertebral body here. Your target is less than 5 centimeters. This obviously changes with age, but it's well correlated with patient disability. Patients with high SVA, positive SVA balance tend to have higher disability scores. So why is this so important? So just to kind of put this into a math equation, we're going to look at torque on the attachment of the spine to the pelvis, right, which is down here. And so torque is measured by the distance at which the force is being applied, the size of the force itself here, and the angle at which it's being applied. So, this R is going to remain constant for each individual patient, and the force is also going to remain constant for each individual patient unless they, end up gaining a ton of weight or something like that. But what's important here is the angle, right? And as this angle gets bigger, as you start to lean more and more forward, you're increasing the amount of torque that you're placing on your pelvis. And this leads to increasing strain on the anterior column because you're leaning forward, you're putting a lot more pressure on the anterior column of the thoracic spine, especially, and also on the lumbar spine. You're putting more strain on the posterior ligaments, You're putting more strain on the erector muscles as they try to keep your body from falling forward, and a lot of strain on the sacroiliac joints and so on. And so again, even if you're doing a one-level TLIF, this is a paper out of Pittsburgh from Conquo, and they looked at a one-level TLIF, and they looked at post-operatively the pelvic incidence and the lumbar lordosis difference in degrees, and whether it had any predictive value in terms of predicting adjacent level disease that would require surgery. So you look here, between 0 and 10, which is the ideal amount of pelvic incidence and lumbar lordosis mismatch, only 6 patients required additional surgery due to additional level disease. But as we went up, even a 1 degree to 15 degrees, you had a positive predictive value of 75% of those patients would go on to require additional surgery for adjacent level disease. And obviously, as you continue to go up, then you have 100% predictive value that eventually these patients will need surgery for adjacent level disease. And that's because, like we said, you're increasing the amount of strain on the adjacent level, resisting the mismatch between pelvic incidence and lumbar lordosis. And I've heard this many times that life is a kyphosing event. We start off with great posture, and as we get older and older, we start to crouch down. But this is important to keep in mind because, if you have a 70-year-old patient who comes into your clinic and they have this, large sagittal vertical axis deformity, then you're going to want to kind of crank them back all the way, and you want their sagittal SVA to be less than 10, your PILL to be less than 10, or sorry, your sagittal vertical axis less than 5. But you're doing too much to these patients. Over time, we have loss of lordosis, increasing thoracic kyphosis, increased difference in pelvic incidence and lumbar lordosis. And this is all due to, as we get older, our muscles get weaker. We start to get osteoarthritis and osteoporosis, and our neurosensory proprioception changes. We just get adjusted to a new normal. And this paper here in the International Spine Study Group looked at basically all the different types of patients and different ages and what their sagittal vertical axis on average was, the PILL mismatch and pelvic tilt. And you can see as you get older, patients start to have higher sagittal vertical axis, the pelvic incidence and lumbar lordosis start to become more mismatched, and they increase their pelvic tilt. But that's normal for these patients. And these patients were healthy. They, had minimal back pain. I guess their ODI was very low. So it's something to keep in mind. There's no strict threshold based on patient age, but it's something to keep in mind. You don't want to, completely correct them back to what they were when they were, 30 years old, because you can end up hurting them that way. And then, as I was doing my research, I wasn't going to focus on the cervical spine, but I saw this picture, and again, talking about torque, right? The average adult head weighs about 10 to 12 pounds. But as we lean forward, as we're more and more glued to our phones, our head has changed from 10 to 12 pounds to now you're having 60 pounds of pressure here at your cervical thoracic junction. And I know everyone's walked around and you see everyone is kind of on their phone, kind of just like this. And I know Timur's looked at, posture in surgeons and how that, how we tend to have a lot more muscular spine disease. But this is something to keep in mind. I guess iPhones didn't really come out until the 2010s. So we're only 10 years into this kind of thing where everyone is basically glued to their phones at all times, barely lifting their head up. I'm curious to see if, 30, 40 years down the road, if we're going to start to see an increase in this cervical kyphosis in patients. But I thought that was just something to keep in mind. So next I want to talk about the effect of age on normal physiology. Time is undefeated. We can work out, eat healthy, do everything we can to help prevent our body from breaking down, but eventually it's just, it's going to happen. So, a lot of the theory is that basically spinal degeneration begins at the disc, right? The disc is what's been protecting our vertebral bodies from excessive forces, cushioning the compression between each level. But as we get older, there's a disruption in the equilibrium of the nucleus pulposus. So there's a loss of aggrecan and water and a decrease in collagen organization that increases the proteases. Concentration of proteoglycans within the pulposus reduces with age from 65% in early adulthood to 30%. And basically what this is all saying that we have a loss of hydration. The pulposus doesn't act like a gel anymore, doesn't move around as well, it doesn't distribute the forces evenly across the entirety of the disc. This is also due to decrease in nutrient transport from the vertebral end plate. And then there's also a reorganization of the nucleus and stiffening of the annulus. Decrease of elastic annular fibers over time results in a less resilient disc, which is why we start to get herniated discs later on in life. And so what does this all mean in terms of the physics of the spine, right? So weight bearing, because of the loss of the hydrostatic pressure, weight bearing causes an increase in the loss of height when we stand up. So your disc gets squished more. This left image here shows a healthy individual with a healthy disc, and they put pressure sensors at the anterior column, middle column, and posterior column here at the facet to see what percentage of the force that they're putting on the construct is being transmitted through each individual space. And you can see here that vast majority of the pressure is being transmitted through the vertebral body. Only 8% is being transmitted back here through the facet. But as we get older and we lose that hydrostatic pressure, we have kind of like a flat tire here. There's a lot of that weight now gets transferred to the middle column and the posterior arch. You have almost an increase in 32% of transferring of the weight through the facets. Obviously, the decrease in height leads to laxity of the annulus, requiring further deformation before the fibers are stretched again. So, at rest, we've lost height in the disc, but you have to lose even more height before the annulus can start to push back against the nucleus. And so, like I said, again, this is what I meant by stress shielding. So the disc is shielding the posterior arch from the stress. And this down here, this is a one level vertebral body disc, vertebral body construct that looked at pressure across the disc. This is a healthy individual, and this is as well grade 1 versus grade 4 degeneration of the disc. You can see basically they placed 2 kilonewtons of force onto the disc. And if you travel, this is closer to the spinal cord here posteriorly, and as you travel forward, you can see even distribution of that force across the entirety of in the horizontal plane and in the vertical plane. But if you look here, there's a huge spike in the pressure being felt by the posterior part of the intervertebral disc. And this is kind of a picture like this, where all of the force is being pushed backwards. There's uneven distribution of the force within the disc. And this is why you almost never see disc herniation go forward. You almost always see it go backwards or laterally, because all of the force is being transmitted backwards through the disc. So like we said, the stress shielding of the spine, as it goes away, we'll have more and more stress being placed on the facets. And the facets then start to degenerate as well due to the increase in load bearing. Osteoarthritis basically occurs here like in any other joint in the body. You have denudation and ulcerative lesions of the articular cartilage here. You get inflammatory hypertrophy and formation of osteophytes and sclerosis of the subchondral bone. And we all know that this leads to lateral recess and foraminal stenosis. And the same also occurs here at the vertebral body. You'll start to get osteophytes and sclerosis down here as the disc starts to degenerate as well. Ligamentous degeneration also occurs with age. There's increased percentage of elastin to collagen, which increases the cross-linking of the collagen fibers, basically reducing the elasticity and the strength of the ligaments. decrease in disc height leads to increased ligamentum flavum laxity, right? As our vertebral bodies get closer to each other due to the decreased height in the vertebral disc, the ligamentum flavum starts to get thicker because it's not being stretched as much, and that's how you get a lot of neurogenic claudication is due to that. The decrease in strength and elasticity can also lead to facet joint instability and therefore spondylolisthesis. And so all this degeneration is basically a cycle of deformity. And this is more important for patients who have long-standing scoliosis, right? They have scoliosis in their 30s and 40s, and they're totally fine. They're able to make it into their 60s and 70s, and then all of a sudden, their scoliosis starts to get worse, and they're starting to have more pain. Now, why is that? Like I said, like we mentioned before, as we age, our muscles become less strong. Our proprioception is, we kind of get used to a different new set point. But if you look at this, you have an axial load applied to a curved spine. You create a bending moment, so the spine bends a little bit forward, causing a deformity. And now that you're farther forward, the same force that you were applying closer back to the center of gravity is now being applied farther from the internal axis of rotation, and you're increasing the force being applied. So that same axial force being applied is now creating a bigger bending moment, a bigger deformity. And that's why once you get to your and your body's not able to resist that as well, that's why patients start to present with back pain later on in life, even though they may have had a long-standing deformity present. So next, I'm going to talk about the physics involved in surgical fusion procedures. I think Biden said it best. I think that we can build the back better. Goals of surgery, obviously decompression of the neural elements, maintaining proper alignment of the spine, and stabilizing the spine until fusion occurs. If you're doing a fusion, or if there's a compression fracture, it's just to stabilize the spine and there's no fusion. So the things I'm going to talk about here specifically are the rod, stress and strain on the rod, fracture of the rod, talk about pedicle screws, pull out, fracture, and how does an interbody play into all of this. So strain and the stress strain curve. Stress is just a force applied to an object. We talked about that already. Strain is the change in length in response to a stress. So you have a compressive force here causing the cylinder to become shorter, or tension forces causing the cylinder to become longer. But what we're going to be focused on is the bending stress on a rod. So this is the stress strain curve here. It describes the stiffness of a particular material. There's the elastic range, which is basically from this point back, and then the plastic range from this point forward. But this point here, the yield strength. So basically you have increasing strain, increasing strain, increasing strain. And once you get past the yield strength, that's the point at which the object that you're just discussing does not kind of pop back to its original location. So as you continue through the plastic range, there's still deformation. This is the ultimate strength here. And then you'll start to get all of the stress that you're applying to the object will result in a change in the object, a permanent change in the object. And then you get to this point here where the object itself just fractures. But this part here is kind of where most of our work is occurring in the elastic range. And so Young's modulus, which is kind of basically the slope of this line here, is this the descriptor of the object's actual stiffness. And so let's look at the stiffness of different types of materials that we are commonly using in surgery. So you have cancellous bone, cortical bone, which is about cortical bone is obviously much stronger at 14. Cancellous bone is at 3. But we're looking down here at titanium, stainless steel, cobalt, chrome. These are kind of like the workhorse of our surgical repertoire, and their elastic modulus is upwards of 50. So they're pretty obviously strong materials, which is why we use them. Each object has a different Young's modulus depending on the stress being discussed, and these are all the bending or elasticity moduluses of the object, because that's what we're mainly concerned about here in surgery. So again, we'll kind of go over the common materials. You have stainless steel, which is very cheap. very stiff, but there's a large MRI artifact, which is why we don't typically use stainless steel. Titanium alloy is less stiff. You can see here the Young modulus is lower, still much stronger than bone itself, but nowhere near as strong as stainless steel or cobalt chrome. There's a high yield strength, meaning it takes a lot of strength in order to get it to deform permanently. And it's notch sensitive. And what is notch sensitive? Basically, when we bend these titanium rods using a French bender or in situ bender, you're creating a notch in the rod itself. And so they looked at the fatigue life, meaning, they put a bunch of strain in on the rod in successive cycles to see at what point does the rod break. And even so, in an intact titanium rod and an intact stainless steel rod can undergo 1 million cycles without any issue. But once you start bending the rod with a French connector or a French bender, or even the connectors that we use, the set screws, the cap screws put a little notch. They're meant to do that in order to prevent slippage or pull out of the rod from the screw. But it does put a notch inside of the rod that weakens the rod itself, which is why it's always better to use a pre-bent rod, so you're not bending it as much. If you feel like you're bending it, unbending it, rebending it, it's probably better just to get a new rod, because you're increasing the fatigue life of the rod itself. And so titanium is very notch sensitive, so something to keep in mind when bending these rods. Cobalt chrome is very expensive, very stiff, and has a very high fatigue strength, which you can kind of feel when you're trying to bend it. It really is very hard to bend. So construct bending stiffness, we talked about Young's modulus, but there are other factors involved in terms of the stiffness of your rod. The equation is, Young's modulus times the diameter to the 4th power over length. And so your diameter is where you're going to get a lot of bang for your buck in terms of increasing the stiffness of your rod, because the stiffness increases at an exponential rate with increasing diameter. And then the length of the stiffness is helpful. If you can imagine, you have a screw at the top end here and a screw at the bottom end here, and you have an interval body that's not being, that doesn't have a pedicle screw, you have X number of stiffness. But if you're able to put this pedicle screw here in between, you've now halved the length at which the bending can occur, and therefore you've doubled the stiffness of your construct. So why is stiffness so important? So kind of harkening back here to Wolff's law, if you're doing a fusion on a patient and your construct is not stiff enough, meaning there's a lot of motion, at the screw and in the rod itself, then you're gonna most likely you're gonna have pseudoarthrosis. You're not gonna get a good fusion. If your construct is too stiff, then there's not enough motion, there's not enough strain on the bone itself, and the bone without strain does not want to remodel, which is why I discussed Wolff's law earlier, because it does come into play once you're fusing these patients. So you kind of want to be in this sort of green area here in the Goldilocks zone in between. And then looking at someone who has a compression fracture and they've kyphosed over, and you put them on the table, you have great lordosis intraoperatively on the table, come back to your clinic and they get an upright x-ray, and now they're kyphosing over again, but all the hardware is intact. It's because the rod that was put wasn't strong enough. Like this is something to keep in mind if you have an obese patient with a compression fracture. That extreme amount of strain on this rod will just end up bending the rod forward, and it won't be able to resist it won't be able to maintain the patient's proper posture. So things to just keep in mind when you're selecting your rods and screws, or your rod. So looking at pedicle screws, kind of go over the quick anatomy. You have the head here, the neck. This is the body of the screw here. You have an inner diameter and outer diameter, and the pitch of the thread. These are all important when discussing pedicle screw strength and also pedicle pull-out strength. Each screw has a cantilever moment. What is a cantilever moment? Basically, it's a bar here, which is your screw, where it's attached it's attached to another rod that's holding it. The cantilever moment is this circle here. So as the force is being applied downward, you have a bending moment here at the attachment site, and the shear force is what's resisting this here. So in terms of this surgery, you have your applied load, which is your weight of the body going down the vertebral body, and then you're bending the screw here as it's attached to the rod, and the fulcrum is kind of here, right where it enters the bone. So the things important to keep in mind for that is mainly the inner diameter, which creates the strength of the screw itself. So basically, screw strength, like I said, is again exponentially related to the inner diameter. So the inner diameter to the fourth power. So going back here, as you increase the inner diameter, the strength of the screw itself increases, and you're less likely to actually fracture the screw. Pull-out strength basically is equal to the material shear strength of the bone, not the screw, and the surface area of contact. So how can we increase pull-out strength in these screws? The first obvious thing is obviously increase the health of the bone. And, if you have an osteoporotic patient, you're not going to get very good purchase because the bone itself is very weak and will likely just kind of be mushed away by the screw and won't have a good hold on the screw itself. Or you can increase the surface area of contact. So this is kind of a negative image of so this dark area here is the bone. This is where your screw would have been. And so you can see kind of the surface area being created by the screw itself. So how do you increase the surface area? One, you increase the difference between the major and minor diameter. So this would be the minor diameter here and the major diameter here. So as you increase that, you're increasing this area here. If you increase the pitch, you're going to get more of these up and down these little mountains, basically. So if you have too big of a pitch, you're just going to have a large, straight kind of, it's hard to describe, but if you look at the formula down here, it's inversely related to the pitch. So as you increase the pitch, you're going to get increased screw pull out. And then the length of the screw itself is pretty self-explanatory. The longer the screw, the longer and the more contact you have with the bone. And so how does screw placement affect pull-out strength? So 60% of the pull-out strength from the screw is from the pedicle itself. You don't have a lot of strength coming from the vertebral body because the trabecula is not as strong as the cortical bone. And it also provides 80% of the cantilever resistance. And so when selecting your screw size, I hadn't really thought about this before, but we always measure the screw size we always measure the pedicle in the axial plane. Why is that? Because the majority of the pedicles are kind of shaped like this. They're more oval than they are circle. So if you were to measure the pedicle in the sagittal plane up and down, you would get 10 centimeters when in reality your XY plane would be 5 centimeters. And so you put in this 10 millimeter screw, and you're going to increase the hoop strength, and you could even fracture the pedicle, and then you're kind of screwed at that point because the pedicle is not going to hold anything. So you want some purchase of the inner cortical surface of the pedicle, but you don't want to go all the way out because, again, too big can cause hoop stresses, and you can fracture the pedicle itself. Too small, you're not getting any purchase on the cortical bone, and you're going to reduce the strength. Tapping allows for easier placement of the screws, but if you can imagine, this paper here talked about the tapping on density of foam. They used the same size tap as screw, and so here I think that basically that if you were to use the same size tap for your screw, then obviously you're making the same size hole, and you're not allowing the screw itself to kind of push the bone out and gain its own purchase, which is why we always under tap when placing the screws. And they say it reduces pull-out strength on average by 8%, but I'm not sure how much I really believe that. Triangulation of the screws is also very important. Why do we never put screws in straight in? Because If you look at the pull-out force that's, that the body wants to apply as it's falling forward and the screw wants to stay in place, but the rod is pulling it out. If you were just to have these very straight screws, 100% of the force is being applied in the direction that it wants to be pulled out. If you have triangulation of the screws, then you're only having an apparent force pulling it out. So if you have an object here and you don't pull it in the same direction of motion, you only get a percentage of the force. So you only get force times sine of the angle at which the screws are placed. So triangulation of the screws can increase pull-out strength by about 30%. Cannulated screws, because they're cannulated, they have a larger minor diameter, which means that the screws themselves are weaker, and you can't get as good of a distance between the inner and outer diameter, right? Because if this inner diameter here is bigger, then you're reducing the surface area of the screw. But fortunately, a lot of the times that we use cannulated screws, if we're not doing percutaneous instrumentation, it allows us to place cement, and that can increase pull-out strength by 250%. Cross-linking briefly, pros, it increases the construct stiffness. You're, again, dispersing the force across both sides. You're decreasing the interval between screws, like I mentioned. It improves pull-out strength and prevents racking. And racking is basically when you have this, parallel, you have a square basically construct, and the force causes the kind of the square to become a parallelogram, and you don't want that in your construct. Cons, it places another notch in the rod, which can be bad in titanium, and sometimes can interfere with bone graft. And then finally, we'll talk about interbody, things that we already know. It improves fusion. It can be used to increase the lordosis of the spine if you have a lordotic cage. But in terms of the physics of the actual construct, you're adding anterior and middle column support. So again, going back to stress shielding in the vertebral disc, these interbodies allow for stress shielding of the posterior column, which a lot of times is gone when you're placing these cages. And it increases the stability of the construct by moving the fulcrum of this construct from right where the screw and the bone interface is here, and basically moving it to the edge. And basically you're now creating a square as opposed to two kind of levers out in space and causing them to bend into each other. So you can see as they moved the cage farther forward in the vertebral body, you had increasing axial compressive stiffness. Sorry. So in conclusion, the human spine is a finely engineered structure that allows for upright posture with minimal effort. Solid foundation is important to maintain that minimal effort. Even at rest, the spine is resisting numerous types of stresses. Degeneration of the disc leads to a cascade of degeneration. Spinal fusion is an imperfect method to restore the spine's natural ability to maintain upright stance. Any questions? Okay.
Hey, Kater.
Hey.
Nice job. I love these biomechanics talks and materials like discussions. Did you see anything about cortical screws? Because I've seen that potentially they have a higher risk for pullout. I don't know. Maybe that's the thread pitch, and maybe it's the orientation or the bone that it grasps. What do you think about that?
Yeah, so I saw a little bit about that. I think these cortical screws they don't go into the pedicle, and so I think a majority of, like I said, the majority of the strength in your construct comes from the pedicle itself. And so if you're not, the thought process was if you're gaining more purchase in the cortical bone, that you would gain strength, but because you're not involving the pedicle as much, that you've kind of lost that strength.
I also wonder if pull out strength, does that linearly equate to the risk of pseudoarthrosis and haloing around the screw? Is that the typical force that's applied for the screw to fail? Is it a direct pull out, or is it?
I think
I'm just not sure.
I think what happens is honestly is it's the cantilever moment, right? As the screw is sitting in its original position and you're getting movement, the screw kind of moves like that, and that's why whenever you're putting the screw, you don't want to kind of move your arm around like this, because you're kind of pushing all the trabecula away from the tip of the screw here, and that basically as the screw is kind of moving, you kind of push away the bone and you're losing that purchase, and then you get the pull out there or the haloing.
Yeah, that makes sense.
Hey, Michael, this is Matt.
Hey.
I have a question on pedicle diameter versus screw outer diameter.
Mm-hmm.
I was wondering if you are aware of kind of the summary of research on kind of at what point do you have an optimization of maximum screw diameter without causing so much hoop stress, causing pedicle fracture, that it defeats the purpose of having a larger pedicle screw. For example, I've only, I'm not a spine guy, but I've only seen a couple papers that looked at kind of pedicle screw ratio. And when the screw is about 80% of the diameter of the pedicle, then it starts to cause some stress fracture. But I was wondering, kind of based on your experience and what the Miami experience has been, like what do you guys do to optimize that? Because I know people that train with Lanky, they try to actually make the screw almost as big as the pedicle itself. And according to some literature, that may actually sometimes cause fracture. So
yeah, I think what we typically do is we only really measure the inner diameter. The cortical bone itself is very thin. And so if you're just grabbing the intercortical surface, then I think you have enough purchase. I don't think you don't need to grab the entirety of the cortical bone, because once you're kind of reaching that outer cortical surface, then you're really increasing the hoop stresses on the pedicle. But I think if you're just purchasing a little bit of the inner cortical surface, obviously when you measure it on a PAC system, there's some sort of margin for error. So you don't want to measure the entirety of the actual outer cortical surface.
All right, good morning, everybody. Today's talk is going to be about sexuality and fertility after spinal cord injury. We're going to discuss a little bit of what we know currently, and then what are the future directions research-wise, and also in regards to the program itself that was run in the Miami project for many, many years. So a little bit of statistics. This is in the United States, but it applies in the majority of the world. So we have 54 cases per million population, approximately about 18,000 new cases each year, and that does not include deaths at the scene of the accident. About 300,000 people live with SCI in the United States. In the 1970s, the age was around the 30 years, and then it climbed up a little bit. So since 2015, it's been around 43 years, still young. Majority are men. And the most of the neurological level of injury is incomplete tetraplegia. And about 45 to 50% of those who are injured at the time of injury are single. And that's important for the next talks step that we're going to talk about. A survey done by Dr. Kim Anderson, who's a pioneer in this field, she asked SCI subject to rank 7 functions in order of importance to the quality of life. Out of 681 respondents, sexual function actually came first in paraplegics and second in tetraplegics, only second to regaining arm and hand function. So sexual function is crucial and important as quality of life matters for men and women with SCI. So what happens? Do they both get affected? We'll talk first about sexuality and we'll talk about infertility as well. So we'll concentrate now on women and see what's going to happen after spinal cord injury. So compared to men, fertility is not a major issue. Birth control is a little bit of a challenge, and we'll talk about why in the next few slides. Immediately following injury, amenorrhea may occur and it lasts for about 4 to 6 months, and in rare cases, it lasts for about a year. Pregnancy and childbirth have more complications than women who are not injured or the same woman before injury, and babies are most frequently born premature or low birth weight. So what happens during pregnancies? Bladder-wise, there's increased risk of UTIs, and it might require changes in the bladder management method that patients use. Risks of anemia and venous thrombosis, skin breakdowns, of course, with the increase of weight and increase in the uterine size, transfer becomes a little bit difficult from the wheelchair or to the wheelchair. Risks of autonomic dysreflexia for those who suffer from autonomic dysreflexia increases, and as we mentioned, preterm labor and sometimes even unattended birth. The bladder pressure that increases during the pregnancy can cause urinary leakage, and also, as we mentioned, contributes to UTI reflux, and that's why we have to observe kidney functions and have to do routine ultrasounds and also some blood work during pregnancy. The diaphragmatic restriction from the increased pressure can also lead to a respiratory compromise or infections in tetraplegics. It puts pressure on the inferior vena cava and the common femoral veins that can lead to worsening edema and predispose to DVT. Constipation increases also because of the bowel motility, and it's also secondary to the hormonal changes that happen, and also increase the iron supplementation that is required during pregnancy can also cause some bowel problems, and that require also bowel program modifications. When we come to labor and delivery, the level of injury determines the ability to recognize labor or assist with pushing, because sometimes they don't feel the contractions. As we mentioned, premature, because there is premature cervical dilatation and also labor risks for premature labor. Atypical labor symptoms that happen is always pain above the level of injury, sometimes referred shoulder or upper back pain, and there's increased spasms and autonomic dysreflexia risks. C-section was very common previously as the method of choice, also vacuum and forceps extractions, but the trends now are trying to educate women with spinal cord injury to help reduce the rate of C-section. We also want to distinguish between preeclampsia and autonomic dysreflexia. And also that labor may require epidural. Postpartum, there are also issues of transportation, and that depends on the method of delivery. Vaginal would be a lot easier to transfer. With C-section, it's a little bit of a challenge. Birth control issues later also because of the risks of thrombosis and DVTs. Lactation and breastfeeding is crucial when it comes to women who are T6 or above, because lactation and breastfeeding can lead to autonomic dysreflexia that triggers more. We need to manage also the accessible cribs so that the woman will be able to, with the wheelchair, manage her baby. And that's why parenting, communication, and peer group interactions are essential for this group. It's a high-risk pregnancy, and then it's a special group after the labor and the delivery for taking care of the babies. Now we come to men. It's more of a challenge with men. There are 3 major contributors to infertility in men after spinal cord injury. They suffer from erectile dysfunction, ejaculatory dysfunction, and if we manage these 2, then we are faced with abnormal semen quality. As we know, there are two types of erection. There are reflex erections and the psychogenic erections. The reflex erections are the one that mostly preserved because it requires an intact S2, S4, and any injury above level L2 level would have preserved reflex erections. The only problem, it's not maintained and it's not good enough for penetrative intercourse. On the other hand, psychogenic erection, that is the one that is mediated by the sympathetic nervous system and requires intact T11 to L2, and that one is really the one that is affected. It's always produced by thoughts or erotic stimuli, and it's independent of direct stimulation to the penis. This one is more, as we mentioned, it's more affected in men with spinal cord injury. We also know that the nitric oxide and cyclic GMP pathway, same as in able-bodied, works the same way in men with SCI. It requires, we need cyclic GMP for the penis to become rigid. And the PDE5 is the one that hydrolyzes that. And so that's where the PDE5 inhibitors would come in picture, and we'll talk about it in the next slide. So how do we manage erectile dysfunction in men with SCI? It's basically the same as we manage able-bodied men, but there are some precautions and some considerations that we have to bear in mind. So first, we will start with the simplest and with the easiest one, oral agents, the PDE5 inhibitors. Sildenafil citrate is the best proven effectiveness, and it's the one that is studied most, and it's the one that has been in the market for the longest period of time. Some would complain of some visual changes. Tadalafil, which is called the weekend drug. There's also some unusual side effects of muscle spasms, some muscle pain. Vardenafil hydrochloride is fast and effective. Avenafil is recently approved by the FDA in the last few years, but there are no data or no trials done on men with spinal cord injury, so we don't have much data. The data that we have are only on able-bodied men. And general side effects for PDE5 inhibitors are headaches, flushing, rhinitis, and dyspepsia. If oral agents fail or they're not giving the satisfactory results to the patient, then we would reverse to intracavernosal injections. They're very effective. It's either in a single component of the prostaglandin E1. There's also combinations in a bimix, which is papaverine and phentolamine. And then there's a trimix, which is a combination of the three agents together. There are some considerations that when we prescribe intracavernosal injections to men with spinal cord injury, is the hand dexterity. It requires good hand dexterity for them to inject the cavernosal tissues. And if they have a partner that would do that for them, that's okay. Also, it's not that discreet, so some patients don't like it, but the patients who use it had very high satisfactory rate and very good outcomes using intracavernosal injection, regardless of the type. Another one is the intraurethral applications, which is a sort of a suppository, intraurethral suppository, and it's made of prostaglandin E1. It's not really preferred by men with spinal cord injury, and there are very few studies about it, because men with spinal cord injury currently, and the most recommended way of bladder management is intermittent catheterization. So already they put a catheter in the urethra, so they don't like to put another thing in the urethra. And also the results are not consistent because the urethral mucosa is really irritated and it's not very healthy, so the absorption would vary from one patient to the other. Next one is non-invasive, and it's simple with a vacuum erection devices using a restriction band. Also, one of the considerations that we have to put on one of the warnings that we have to tell the patients when we prescribe these devices is they have to be very aware of the presence of the restriction bands, and they have to immediately after sex remove the restriction bands so that they don't sleep with the restriction band in there, and that will cause major side effects. If all these fail, then we go to the surgical option, which is the penile prosthesis. And we have two types of prosthesis that are used. There is the malleable, or sometimes called the semi-flexible, which is the one that stays erect, and then the patient would bend it, and then it would not show that it's erect, but it's still erect. And that is good for patients who have poor hand dexterity, because it does not require a lot of manipulations, and also makes catheterization a lot easier with an erect penis all the time. Some patients prefer that, but there's also a risk of erosion because it's a cylinder is always full and erect, and that can cause some erosion, especially that the patient does not feel it. And with the friction with underwear, friction with the clothes, friction with the chair or the wheelchair, that can cause some erosions. The other type is the inflatable, which is the preferred penile prosthesis. It has lower risk of erosions, but on the other side, it has higher rate of mechanical failure, because it's, as you can see, it's all mechanical. You have the two cylinders here. You have the mechanism that pumps fluid here into this reservoir, in and out of the reservoir. And that requires also hand dexterity, because they need to activate and deactivate this device here. And without good hand dexterity, is going to be difficult unless they have a partner that's willing to do that. Major complications, the malfunction, need to reoperation, the erosions, pain, and of course, infection, as any foreign body can cause early infection or late infections. Now we go back to ejaculation. So there are two phases for ejaculation: emission, which is controlled by T10 to L2, is sympathetic control, and it's consistent of contractions of the seminal vesicles and the prostate, leading to expulsion of sperm and seminal fluid into the posterior urethra. That is the phase where the patient feels the ejaculatory inevitability, followed by the expulsion phase, which is multiple and combinations of controls. They have a sympathetic control that causes bladder neck closure, and then there is relaxation of the external sphincter and parasympathetic rhythmic contraction of the bulbocavernosal tissues, and then there's somatic influence from the pudendal nerve core pelvic floor muscle contractions, and that results in semen spurting out of the urethral orifice. So some investigators through the years thought about what they called the spinal ejaculation generator. So they thought that there is a bunch of neurons in the body that control the ejaculation mechanism, and they generate that. And they did first animal studies, and they found that these are present in the L3, L4, and then they control the rest of the body. Then a French scientist worked on doing some human studies, which is very interesting, as they took postmortem spinal cord segments from 6 men and 6 women. They looked at it and they found what they call the cholinergic neurons, and they mostly located in the mid-lumbar segment. And of course, they found higher densities of these in segments that were taken from males more than females. And then they tried to correlate that with success to penile vibratory stimulation in 384 men with spinal cord injury. And they found that people who had injuries in between L3 and L5 always had PVS failures. So they confirmed in their opinion that this spinal ejaculation generator is also present in humans between L3 and L5. So how do we currently manage an ejaculation in men with spinal cord injury? There are methods for either semen or sperm retrieval in men with SCI. The gold standard and the method of choice is penile vibratory stimulation. There's also electroejaculation, which is the oldest method actually that was available a long time ago, and we'll talk about the history about it in the next few slides. Prostate massage is also used. And if all these fails, then there's surgical sperm retrieval. So what are the pros and cons of each method? The PVS is safe. It's have 86% success if the level of injury is at or rostral to T10. That's very important to realize that. In order to attain the 86% success, the level of injury has to be T10 or a rostral. It's inexpensive, can be performed at home by most patients. And what we mean by most patients, that the patients that are prone to autonomic dysreflexia, they have to be pre-medicated. So we have to train them first and make sure that it's safe for them to use that after a few trials in the clinic. It yields the highest total motor sperm count, and that's very important. This term we're going to repeat a lot during this lecture, so make sure that you realize that that's one of the most important numbers that we look for during any either insemination or IVF procedures. As we mentioned, it has 15% success rate if the level of injury is correlated to T10, and patients, of course, are prone to autonomic dysreflexia depending on their level of injury. Electroejaculation is safe, and we say nearly 100% success rate because some patients who have lower levels of injury are in the lumbar region, and they cannot tolerate the electroejaculation in the clinic. We can take them to the OR and do it under general or even conscious sedation, and we can produce an ejaculate. But some of them don't want to go through this, or the logistics of recovering semen and sperm with this method is more expensive than even doing the surgical. So that's why it's not 100%. But if we do everything to collect it, it can be 100% successful. But of course, the cost is similar if it's done in the clinic, in the outpatient clinic. It's of course more high if we go to the OR. The startup equipment cost is relatively high. So this machine that you see here, it's a simple machine, but the cost is around 20K. And of course, it's invasive because you have to put the probe in the rectum, and we talk about this method in the next few slides. It requires specialized training, so only trained physicians can do this procedure, and it yields lower antegrade motility than the penile vibratory stimulation. The prostate massage, there's no specialized equipment, and fast and easy, inexpensive, but there are inconsistent results. No reports have been done about if it triggers autonomic dysreflexia or no, and there are very, very few studies that are done using the prostate massage method. Surgical sperm retrieval, it's very well recognized. It's done in a majority of the infertility patients who have some issues with the sperm production. No specialized equipment is necessary, less risk of AD in some patients, but it's higher cost, and it yields the lowest total motor sperm count. Again, that's the term that we're going to speak about a lot. And of course, because it has the lower number of sperm, then it commits the couples to the highest cost of assisted reproductive technologies. So we spoke a lot about autonomic dysreflexia. What is autonomic dysreflexia? It depends on the level of injury. If the patient is T6 or above, then any stimulation, such as the PVS or EEJ, below the level of injury would trigger uninhibited sympathetic overflow that will cause bradycardia, hypertension, pounding headaches, flushings, and a lot of these symptoms. So what we usually do to minimize the effects of autonomic dysreflexia is we give nifedipine. It's a calcium channel blocker. We give it sublingually before stimulation. And that takes about 10-15 minutes to work. If the patient does not want sublingual or want to do it at home after they are trained, then we recommend that they stay 30 to 45 minutes after taking the nifedipine before stimulation. So penile vibratory stimulation, as we mentioned, the first line of treatment for anejaculation and venous-spinal cord injury. There are many commercially available vibrators. As you can see, there are many vibrators here, starting from massagers to The Fredicare 1.0, which is the oldest. This one is called the Fredicare Clinic. It's a huge machine. That was the first one that was FDA approved. And then, of course, there's Mr. Potato Head here. And this was given to us by one of our patients who said that he only ejaculates by having these vibrating feet of Mr. Potato Head. So whatever works for the patient, it works. But the trick is not all of them work because of the amplitude. And that's what we're going to talk about here. So Dr. Jens Sonsken, he is an MD PhD from Denmark, who is the first one to engineer this first Fredicare that was designed specifically to induce ejaculation in men with spinal cord injury. And we worked for many, many years on trying to find out why some vibrators work and some don't. And he, after many studies, found out that the amplitude, which is the distance that this head travels when it vibrates from the base of the vibrator to the head of the penis that's going to be underneath this pad, is crucial. And he found that 2.5 millimeters is the most effective amplitude. So other vibrators that don't work is because they have very low amplitudes, and that does not assist in inducing the ejaculation in most patients. Now there is a Fredicare 2.0. It's newly designed and it's manufactured here in the United States. It's available in the market. And even now, we don't require prescription to get that one, but we always recommend that the patients be assessed first, as we mentioned, for risks of autonomic dysreflexia or any other risks and aberrations to the penile skin. So we want to make sure that it's safe for the patients, but it's available in the market. And that's the one that we currently use. Before it was introduced into the consumers, a panel of 10 world-renowned experts from the US, Canada, Denmark, and Sweden came to the Miami project here and try to do a simple study to evaluate the effectiveness of this vibrator before allowing the manufacturers to have it in the market. And it was tested on 15 men with SCI. All the subjects have previously responded to other types of vibrators, either Fredicare 1.0 or other vibrators that were available in the market. It was very well tolerated. No complications resulted out of it. And all subjects recommended in a questionnaire where they were asked, do you recommend this Fredicare 2.0 to other men with spinal cord injury? They all said yes, it's effective and very well tolerated. And currently, that's the only device that is available in the market that is specifically designed for penile vibratory stimulation in men with spinal cord injury. So what do we do when we have the patient come in for a penile vibratory stimulation procedure? So first, the patient is transferred to the exam table or the hospital bed. As we mentioned, for people who are TS or above, we give them 20 milligrams of nifedipine. We start with that. If the blood pressure is not tolerated or the vital signs are swinging, then we might add more dose to that. The bladder is emptied and a buffer is added just to make sure that there's no retrograde ejaculation. Then the vibrator is applied for 2 minutes. Most of men with spinal cord injury would respond within 2 minutes. If no response, then we wait a little bit, few minutes, and then we try again for a maximum of 10 minutes during one trial. During all this, for the first visit, even if the patient, this is the protocol that we follow. If the patient, even if his level of injury is not T6 or above, we put a vital signs monitor in there and we monitor the vital signs every minute. If no ejaculation, as we said, we stop, we inspect the penile skin, and then we resume the ejaculation. If antegrade was collected, would be collected in a sterile cup and examined. Retrograde are collected by emptying the bladder with catheterization. If one vibrator fails, we did a study using 2 vibrators. It's what we called the sandwich method. And that salvaged some failure to one vibrator device. Vibrec device, it was available in the market. Currently, sometimes it's available off the market, but it's not readily available through the manufacturer. It was designed based on our study of the two vibrators. And as we mentioned in separate studies, it salvaged a lot of failures to a one vibrator device. Also, some patients don't respond to one vibrator alone. So what we did a study, and there's based on another study that was done by actually a physician who was also on a wheelchair, that tried it on himself, and using abdominal electric stimulators, which is available in the market, simultaneously with penile vibratory stimulation, and that salvaged some of the failures to single vibrator or even a sandwich. So these all combined methods are the ones that, when we reported 86% success rate for patients who are T10 or above, that is a combined methods of single vibrator, sandwich, or using electrical stimulation. So if PVS fails, the patient then is referred to electroejaculation. This is the Seeger model that we currently have. It's a Seeger model 14. It is developed by Dr. Steven Seeger, who's a veterinarian who adopted this method from using this. He is an expert in electroejaculation. He's the inventor of this machine, and he has been hired through the years by many zoos for listing species and for other veterinary medicine efforts to increase species of other animals. And it's an interesting story about this machine. It started basically back in the 1930s, and it was the government of Australia who was concerned that their sheep were not as prolific as the sheep from England. So they assigned Mr. Gunn to look at this and find out what are the best answers to it. So he looked into it, and he found out he is the actual first one to develop this electroejaculation technique and doing the stimulation. And the picture that you see here is a very old picture, as you see, it's very grainy, but it's actually the first machine here, first ever electroejaculation machine. And the probe is here, and it's used in RAM. And of course, it's supposed to be in front here, but they're doing that for the sake of the picture, which is very interesting. So what do we do? How do we do this procedure currently? So patients, as usual, are assessed for risk. If there is a risk of autonomic dysreflexia, they are treated with nifedipine. Bladder is prepared because there's the risk of having retrograde ejaculation, which technically means that the ejaculating stuff coming out of the penis would go back into the bladder. The patient is placed in the lateral decubitus position. Anoscopy is always performed to make sure that there's no abnormalities. A probe is placed in the rectum. The current is delivered, and there are two different techniques of developing the current. There's either continuous current that goes higher up till you get into the, you get antegrade ejaculation, or you can go what we call interrupted current delivery, where we go few volts, like 2 or 3 volts, and then we go down the baseline, and then we go up again and keep going higher up and going to baseline till we get an antegrade ejaculation, and also retrograde is collected. So what is the advantages and disadvantages for each? So both procedures are simple, effective, and relatively safe after assessing for the risk of autonomic dysreflexia, of course. But the advantages of EEJ usually works when the PVS fails and there's no risk of penile skin. There's some risk of rectal mucosal damage, and that's why we all say that it has to be done by a trained physician. And also, exam should be thoroughly done before introducing the rectal probe. What are the advantages of the PVS? It's preferred, of course, by more patients because it's less invasive, has better semen quality, And also they can be used at home for attempts of home insemination. So the patient will be trained, will take the vibrator home, will try to get an ejaculate and do home insemination. And we have a lot of patients that had success having children using the penile vibratory stimulation and home insemination techniques. So we already found ways to get an ejaculate out of men with spinal cord injury. And in our group here, we have a lot of database points because we have over 700 men with SCI in our database. We perform thousands of PVS and EHA procedures. So we wanted to look at the quality of the semen that is produced by men with spinal cord injury. Macroscopically, as you can see here, some of them have a different color, and we'll talk about that in the next couple of slides. Microscopically, we can see some cells and some debris in there. And then the most important part are the semen parameters. So as you can see here, we have three main parameters that we look for in any semen analysis. We look for the count, we look for the motility, and we look for the viability, the numbers that are alive. And as you can see here, there is no huge difference, no statistical difference when it comes to count. So patients with spinal cord injury produce enough sperm in their ejaculate. But strikingly, there's huge statistically significant difference between controls, that the green bars here, and SCI, the red bars, when it comes to motility and when it comes to viability. So why is that? A lot of studies were done to see if this is due to life quality or lifestyle changes following spinal cord injury. Is it because the bladder management method might make a difference? Is it because you sit in a wheelchair for a lot of time, so there's scrotal hyperthermia? They don't ejaculate frequently like able-bodied. Maybe the method will cause a change, or maybe it was good earlier in injury and after years post-injury, it changed. So all these were studied. When it comes to bladder management, it was not a huge difference. The best quality was obtained mainly using intermittent catheterization, which is used right now, but none of them reached the normal levels or the levels that are considered normal by the standards of the WHO, which is our gold standards for deciding reference values for normal and abnormal in semen parameters and sperm parameters. When it comes to scrotal hyperthermia, a study was done here with our group to find out if it really is causing it. And we found out that there is no really changes in scrotal temperature between SCIs and control. As you can see here, it's basically the same, no statistical differences. And interestingly enough, out of the people that were studied in this cohort, there were 10 men with SCI who walked with crutches. So they did not sit in a wheelchair. And at the same time, the semen quality was poor as other groups who were in a wheelchair. So we concluded that scrotal temperature is not really a major factor in this poor semen quality. Also, frequency of ejaculation did not really show that much of an improvement. There are very few studies that show that it improved, but the majority of the studies showed that there's not really that much of a difference. Methods of ejaculation. So if you remember, there are some men with spinal cord injury, I would say about 7 to 9% that can masturbate. The majority of them are using PVS or EEJ. And then we studied, so we had controls, and we had also men that masturbated, men with PVS and men with EEJ in our database. And we looked at the differences in the volume, count per cc, which is important, and the motility. And as you can see from this, the best, of course, motility was for controls, followed by masturbation and PVS and EEJ. But if you look here, there is not a difference that would move them to be in the able-bodied or like the normal WHO criteria for percent motility, they're still lower. So it doesn't make that much of a difference that the method would be, we assume that masturbation would give you levels that are close to the controls, but it's not the case. As you see here, the differences are still higher with masturbation, but it does not reach the level of the controls. We did two studies. One was a cross-sectional study, and other one was longitudinal study to see if there's any changes in the quality after years post-injury, and we confirmed that there are no changes in there. So it's not lifestyle factors. So what would be the reason for that? A lot of studies were done on the hormonal profile to see if there's any difference. And it's, as you can see from this table, it's all over the place. There are higher, there are lowers, but it does not give us any indication that there's a specific hormonal profile that is the cause for this changes in the semen profile. Maybe it's the accessory glands, maybe it's the prostate, maybe it's the seminal vesicles. We studied, and others studied this to see if there are changes or no. We found out, which is an interesting study that was done by Dr. Brackett and Dr. Lin. They are pioneers in this field, and they were here before they retired, to see the effect of adding seminal plasma, which is the fluid. So when we get the semen, we spin it and we get the supernatant. That is called the seminal plasma. So they got the seminal plasma and add that to sperm from able-bodied, normal sperm, normal parameter sperm, and the motility dropped. And the other way around, when they get the control seminal plasma, the motility improved. So is it something in the seminal plasma that is secreted that is causing this effect? They also did a comparison between getting sperm directly from the vas deferens. So before it has the contributions. So the semen, the fluid contribution from the semen is majority is from the seminal vesicles and from the prostate gland, and some from the urethral gland, periurethral glands. But the majority is from the prostate and the seminal vesicles. So they went before that into the vas deferens to collect sperm while it just came out of the epididymis. And they found that it's a lot better and statistically better than the SCI when it comes to motility and when it comes to viability as well. Then they were able to get prostate biopsies from controls and from SCI subjects to see if there's any difference or no. And histologically, there were no evidence of inflammation. Looked at the PSA, there are changes in the PSA, but these changes is only proven by higher serum levels, but lower semen levels of PSA compared to the age-matched control. So there are some prostate dysfunction here. We went and studied with a group from Brazil that they do spectrometry-based quantitative proteomics. They studied 12 SCI subjects. We sent them seminal plasma from 12 SCI subjects, and they wanted to study and see the immune responses and immune effects in there. And interestingly, they found decreased kallikreins, which are the proteins that are produced by the prostate gland. And that would indicate that there are some prostate gland dysfunction or secretory gland dysfunction, mainly the prostate. As we've seen in the other picture, we see this is brown semen that is present in about 30% of men with spinal cord injury. And we thought that is produced from, we're trying to figure out where is it produced from. So the left tube, this is a prostate massage that was done 1 minute before PVS. And as you can see, it's clear. So there's nothing wrong with the prostate fluid. After the ejaculation, we've seen this brown semen. So it's not from the prostate. It's not being contributed by the prostate. We looked at the seminal vesicle, and we found that there is abnormally high numbers of sperm in aspirates from the seminal vesicles. This was done by Dr. Dana Oller from Michigan. And it's interestingly enough that that proves that there's some sort of an abnormal transport and storage, because usually you should not see any sperm in the seminal vesicles. Seminal vesicles would have sperm moving forward to be ejaculated, but he found a lot of sperm with higher numbers in the aspirate from the seminal vesicles. So is it a transportation issue? It might be the case as well. As we've seen in the picture that I showed you, but under the microscope, there's a lot of cells. So we thought it might be leukocytes. So a rat study was done, and they found a lot of leukocytes in the seminal vesicles as well. So there might be evidence of some seminal vesicle dysfunction. This is the picture that I was talking about. There's a lot of cells in here, numerous white blood cells based on this stain. And we were thinking, what are these? So a cytofluorographic identification was done to see what are these, and they ended up being activated T lymphocytes. What are these lymphocytes do in the body? They produce cytokines. We studied cytokines in the seminal plasma of men with spinal cord injury, and we found elevated levels of inflammatory cytokines as the IL-1 beta, TNF alpha, and IL-6. And that started us thinking about, okay, so there is inflammation, there's cytokines that are excreted in there. What do we do to manage this? In a cup, 2 studies were done by the group. One of them was adding monoclonal antibodies. The other one was adding receptor blockers. And we found that there is improvement in motility in both studies, but the most statistically significant improvement was when we added the 3 together. So when we add each cytokine alone, monoclonal antibodies against one cytokine or a receptor blocker against one cytokine, it does not improve that much as when we add the 3 together. Logistically, that would be a challenge to move that into the bench side. So what is the mechanism that is leading to the elevated cytokines in this man? Is the inflammasome complex involved? With neuroscientists from the Miami project, with Dr. Bakari and Dr. Keen and Dr. Dietrich, we studied that inflammasome complex. They are expert in that. So what is the inflammasome complex? It has a sensor protein, has an adapter protein, which is the ASC, and a procaspase-1. When they are triggered and activated, the procaspase-1 is changed into the active form, caspase-1, which changes the pro-IL-1 beta and IL-18 into the active forms and the mature forms, IL-1 beta and IL-18, which is the cytokines that we've been studying. So maybe the inflammasome has a role in that. We looked deeply into semen and sperm of men with spinal cord injury, and we found that these components, the caspase-1, the ASC, and the pannexin-1, which we're going to talk about in the next few slides, were all statistically and significantly elevated in men with SCI than in controls. We did immunocytochemistry, and we also found them in SCI. Signals were present of caspase-1 and ASC in SCI and not in controls. Also, there was correlation between the motility and caspase-1 in the seminal plasma and ASC also in the seminal plasma. In vitro, in a cup, we studied anti-ASC, and it improved the motility. So we did add anti-ASC to semen of men with spinal cord injury in a cup, and we found that is improvement in there. So what is the pannexin-1? The pannexin-1 is a cell wall channel that, when activated, would cause this inflammasome complex to be activated, and then would lead to the IL-1 beta and IL-18 production that we talked about before. So what if we can block this channel? We found that the probenecid, which is a medication that is used to treat gout for many, many years, actually blocks the pannexin 1 channels. We did a pilot study where men with spinal cord injury were given probenecid orally for 4 weeks, and then the semen quality was analyzed before, after treatment, and then 4 weeks after stopping the treatment. And we found that it was well tolerated. And as you can see here, sperm motility improved in each subject. And one of the important categories when we talk about insemination is the rapid linear motility, was how fast the sperm move. And we find in this slide here, in this graph, that rapid linear motility was really statistically improved after probenecid treatment. Sorry. So then we studied seminal plasma from men who were treated with probenecid to see what is the effect. And we found out that it actually affects the innate immunity, which in turn would cause the increase in sperm motility. So what are the options for a couple with a male with spinal cord injury? It represents an interesting medical and ethical problem. So in able body, the first thing that we do is get an ejaculate and examine it and look at the semen quality. That's not the case for men with spinal cord injury. And we did a survey when we asked practitioners, why you're not performing PVS or EEJ? And 45% said they don't have the equipment, and about 40% said they're not aware or not trained. EEJ was even more, 60% don't, 40 would not, and the majority would consider that as a logistically problem, like third of the respondents. So then surgical sperm retrieval would be the option, which would commit the couple to the most invasive and most expensive options. When you have an ejaculate, you have more options. You have intravaginal insemination and you have intrauterine insemination, which is still a lot simpler, closer to the natural method, and a lot cheaper. And what do we need really for that? Remember when we talked about the total motile sperm and the counts, this is what we need. The majority of the respondents to the survey, the majority of them were reproductive endocrinologists treating their female partner, said that we need about 1 to 4 million total motile, and then maybe a third of them said 5 to 10 million. Do we get that with spinal cord injury? We asked, do you counsel? Do you offer the couples? 54% said no on IUI, on home insemination, and 34% said no on IUI. But do we get that? Yes, we get. The majority, as you can see here, have enough sperm for any of these procedures. And when we compared the pregnancy rates, we found that intravaginal, intrauterine, and even IVF pregnancy rates are very similar to able-bodied couples. The only difference between maybe PVS and EEJ is the PVS have a higher success rate. So what are the future directions? What are we trying to do? So based on the studies that I showed you before with the probenecid having success on inducing that, this study was done as a pilot study with only 4 weeks of treatment and with only 1 dose. So the next approach would be doing a double-blinded placebo-controlled clinical trial where we're using different doses of probenecid, and we're going to give it for 90 days because that's a full spermatogenesis cycle. And then we'll follow these patients for 6 months. And then also to prove not just the effectiveness, but the safety, we're going to do some toxicity studies, including doing what is called the sperm DNA fragmentation in order to find if there's any damage to the sperm DNA. The side effects will be rigorously monitored, and testing also the other oral agents. Also, we want to do some animal studies. So we started doing to test the techniques where we're using rats that are injured and an injury model rats, and we are going to test the inflammasome inhibitors, some of the anti-ASC components, And we're going to use the intraperitoneal route, and then we'll see the effect on sperm and also on the reproductive organs. And that's one of the potentials that we're having for an R01 NIH grant. What are the program's future directions? So right now, the program is labeled as a male fertility research program. My intention is just moving it forward to be a urology rehabilitation program, where we are going to study sexual dysfunction. We're gonna also collaborate with the scientists and researchers from the urology department to do neurogenic bladder and bladder cancer early screening studies. We want to do female studies, especially sexual dysfunction in females. And also we want to do regular training and educational workshops. And we actually have 2 workshops that are scheduled for the month of February and the month of March. And anybody who is interested in doing that, we're going to do actually live patients that we are going to do PVS and EEJ on them, and then we'll show exactly the techniques and little tips and tricks in order to get a better success rate. So the take-home message is treatments are available for erectile and ejaculatory dysfunction in men. They present a unique infertility population. The semen quality is impaired. We think it's because of the toxic seminal plasma. Technologies are available to overcome this. We want to assist the patients in getting least invasive, less expensive methods in order for them to be able to conceive and have a child naturally. And the choice, of course, as we mentioned, is controversial when it comes to that. I just want to introduce you to my team. So I've been here over 18 years and this program and in the university. Ori is my new research assistant, and he will be, this is his contact. If you need anything, maybe take a screenshot of this. If you need to refer any patients to me for assessments, then he'll be able to help in scheduling this. Kajal is an assistant scientist, a PhD. She works at the Department of Urology and assists us a lot, and she's doing most of the studies on the animals and the rat studies that we're doing. And also Joginder, he's our research associate in urology and assists with also some of the techniques and the semen analysis, because he's a major contributor in the andrology lab in the Department of Urology. And as you see here, we were located in the Lowe's Pope. We currently still do the animal studies in the Lowe's Pope, but right now we are in the Christine Lynn Center, and we have our clinics here. We have some of our lab stuff here. And these are my contacts. If you need to email me, these are my Twitter handles and Instagram. If you need anything, I'm available to help you with all your either educational needs or with assisting with patients that you want to refer to me. Thank you, and thank you for attending, and open for any questions.
Thank you very much, Ahmad, for just an outstanding presentation. And congratulations to yourself and everyone else that has pioneered this exciting work over the years. I guess my question is, what do you think are the mechanisms by which spinal cord injury produces abnormal semen that then leads to all of these downstream effects on sperm mobility and things of this nature? Is it due to neurogenic mechanisms after spinal cord injury, or do you think it could be that there are other mechanisms out there? Thank you.
Sure. Yeah, that's an excellent question, because I think that inflammatory processes cause all these deleterious effects. But I also think that the inflammation starts earlier. So the spinal cord injury will cause some inflammation in the testicular tissues. It is not affecting numbers, but it's affecting the transport, because the epididymis is the major control. It's the area where the sperm mature and develop their motility. So if we get sperm from the testes, it does not really have motility. It might be only twitching. If we get it from the epididymis, we'll see normal motility. And the good thing about the animal study is we are taking the sperm from the epididymis. So we want to see if there's really any changes in the epididymis, and that will take us all the way up to the tract where we can study that. But of course, inflammatory contribution, and that's why you see a lot of the cytokines that are elevated and a lot of the inflammasome components also elevated.
Great. Just one more question. Do people with a chronic stroke or traumatic brain injury also have issues with fertility?
So it's not sperm quality, but it's it's the ejaculation.
Okay, so it's
So ejaculation is a major issue, and we help them with the same techniques. But of course, if we're going to do electroejaculation, it has to be under general anesthesia. And I actually had a couple of patients in the clinic in urology that had TBI and he could not ejaculate, and we were able to help with having the semen from using electroejaculation, and then we froze that sperm to be used in the future insemination process.
okay. So the sperm quality
The
is
quality in the majority of the times is not affected,
is not affected. Okay, great.
but the ejaculation part is the one that is affected.
Great. Okay, thank you very much.
Sure.
Other questions? I ask because we're studying this hypothesis that CNS injury releases extracellular vesicles or exosomes into the systemic circulation, and that these exosomes find homes in different organ systems coming from the brain or coming from the spinal cord. And we now know that these exosomes have high levels of the cargo of the exosomes have high levels of inflammasome mediators, and they are in stroke patients and TBI patients and spinal cord patients. So anyway, I was kind of thinking that this may be a common mechanism that would affect sperm quality after CNS injury, but you're telling me that the quality is not affected in these other neurological problems. So anyway, we'll go back to the drawing board and think about the mechanisms that you're doing.
There are
Thank you.
actually some studies that are done on exosomes, but in just able-bodied and infertility patients. We're doing some in the Department of Urology and other things like varicocele and other causes of infertility. So it's also a good venue, and we might be able to explore it and see.
Fantastic. Thank you again.
Sure.
Any other questions from the group, please? Okay, Maud, thank you very, very much for an outstanding presentation, and Happy New Year to everyone.
Yeah, same. Thank you. My pleasure.
Have a great day. Bye-bye.
Bye-bye.